Any questions from anything for the test? Maybe had a chance to look at it a little bit more. Maybe not. PG. Okay, yeah. So, sorry, you're triaging until the next test. That's understandable. If you have questions, please feel free to email me over the weekend. I'll try to get back to you as best I can. Okay, so next we're gonna start off with the last section of Farm 2, and then you guys are almost done with me. How exciting is that? Oh, I should hear some more cheering from you guys, right? Okay, well, this one's going to be a bit of a snoozer because we were talking about anesthetics. Yeah. So that's a very cute picture. That's a very big rabbit. I would be very intimidated if that was my anesthesiologist if I was going in for surgery. Just hair everywhere would just be no good. But anyway. All right, so we're talking about anesthesia, and really this is more kind of focusing on the sedation aspects of things, because again, your surgery is a lot more just kind of mechanical, not as many drugs from that standpoint, but certainly lots of drugs from the anesthesiologist perspective. And so some of the definitions we'll talk about, one being balanced anesthesia. This is just referring to using kind of multiple modalities of anesthesia, analgesia in order to sedate the patient. So you're going to see we're using a mixture of drugs, usually those both by the inhaled route and then also those by the intravenous route. And so we're going to use a combination of those two. Sometimes you even see some pre-meds that are done sometimes orally, sometimes intranasally. We'll talk about those a little bit later. But really the idea is to use multiple drugs in order to lower doses of both and then to provide a better anesthetic experience for your patient. So obviously inhalation anesthesia is going to be that's induced by inhalation of drugs. So we have a couple of different inhalation anesthetics that we'll use from that standpoint. Obviously ether used to be kind of the old school one that we used to use very frequently. Does anyone know the problem with using ether? Very flammable, so they had lots of problems with that. So obviously you don't want to start fires when you're performing surgery. Very frequently they would have you'll see this in kind of an old school like surgery suites, but there's like kind of a line at a certain part of the wall where basically anything that was like electrical, they had to like kind of have the outlets above that because there was a spark risk, because ether would only kind of go so high into off the ground, basically because it was more dense than air. And so if you had anything that was like a spark risk below that, you were running the risk of having the ether light up, and that would be no good for your patient, right? So we don't use highly flammable gases, fortunately, anymore, but we will talk about some of the other kind of drugs we use since then as inhalation anesthetics. Some other definitions we'll look at include the minimum alveolar anesthetic concentration. We'll just shorten that to MAC. Basically, this is the concentration that the inhalational anesthetic has to achieve in the alveoli in order to get this kind of standard response from about 50% of your patients. So basically 50% of them would not be responding to painful stimuli while 50% would be. Is this the level you normally want to get to? No, right? You don't want 50% of your patients to still respond when you're slicing them open, right? So that'd be no good. So, but that is a good way to kind of compare and contrast different drugs together. So you can kind of look to see, things that have a lower MAC are going to be more potent agents versus one that have a higher MAC. You're going to need more of that gas, more of that, because again, when you're inhaling those inhaled anesthetics, that's taking the place of oxygen, right? So you got to make sure that you have a good balance between not having too much drug to make sure you still get enough oxygen to the patient. So that can be a good thing when you're looking at to compare these drugs. Analgesia is just going to be the state of decreased awareness of pain. Sometimes you'll find that you'll have some amnestic kind of properties with a lot of these medications. We'll talk a lot about anterograde amnesia that you can induce with some of these drugs. And one of the big things to focus on here is to note which drugs are going to have analgesic properties, which ones are going to have more sedative properties. There's very few drugs that actually have both, right? And so we're going to kind of look at some of those. It's important you have kind of both aspects of it, right? You want to make sure that you just don't have a sedate patient. You oftentimes want to make sure that they are not feeling or not at least responding to the pain that you're perhaps inflicting upon them. And then general anesthesia is just going to be the state of unconsciousness. You'll normally include both analgesia, amnesia, and then also you're going to have this skeletal muscle relaxation, which again is good. You don't want your patient to be tensed up if you're like trying to cut into their gut or whatever happens to be. And you lose a lot of those reflexes, right? Typically, what is your respiratory drive like when you're in this state of general anesthesia? Non-present actually. So oftentimes these patients are intubated. So again, airway management is going to be really big with a lot of these drugs. And this will be important when we're talking about which drugs can affect the airway the most, because that'll be important when we talk about things like conscious sedation. So have you guys heard that term, conscious sedation? What does that refer to?
Procedural sedation. Your airway can watch.
Yeah, so a lot of ortho reductions kind of fall into conscious sedation. So essentially, the patient's still somewhat with it. They're not completely out of it, and they still can maintain their respiratory drive for the most part. And so we'll look at different drugs that can affect that in different ways. So for instance, dealing with procedural sedation, which we do a lot in the emergency department, we will use certain drugs for different types of patients. So for instance, ketamine's a really big one for pediatrics, whereas you don't want to use that for adult patients for some of the side effects we'll see as we kind of go forward. So again, anesthesia, just this physiologic state induced by the general anesthetics, and then the extent to which it's able to produce these effects is going to be very dependent on both the specific drug that you're using, the dosage that we're applying here, and then also the clinical situation, what's going on specifically with the patient. So we're going to look at some how we can compare and contrast these and see which, when one drug might be better than another, or where we can kind of use the combinations of different drugs. So concerning amnesia, typically this is going to be the abolition of sensation. So basically, a lot of times patients may still be experiencing pain, but they're not really going to remember a lot of it. So they're going to have unawareness of the situation, and then obviously the amnesia can either be considered to be anterograde or the retrograde. So what's kind of the difference between those? So anterograde is I give you drug, and then where do I lose memory? Time backwards or time forwards? Yeah, time forwards, right? So that can be a big thing. So I'm sure no one experiences during spring break, but when you drink high doses of ethanol, what type of amnesia is that? Usually anterograde, right? So you may have been conscious during that time frame, but you may not remember all of what had happened during that time. You remember stuff that happened beforehand, so you don't really have the retrograde amnesia, but it's all anterograde. Same thing happens with a lot of the like benzodiazepines that we give to a lot of these patients, where they come in, they have a broken bone, there's obviously display, it's very painful for them. We'll give them some, say, intranasal midazolam, and after that point, they don't really remember what happened after that. So they may still have been having some pain issues, but they don't remember it. So for the most part, it didn't happen from their standpoint. But you also have some inhibition of some of these autonomic and sensory reflexes. Skeletal muscle relaxation is a big one, because again, imagine trying to reduce a fracture and your patient's very, very tensed up. That can be very difficult to do, especially if you're doing like a lot of like large bones in the legs and things like that, where the patient usually has a lot more muscle. That can be tough. So we like to have some of that skeletal muscle relaxation happening there. And so, and then we'll talk about sedation as well. So again, being defined as a decrease in activity, alertness, arousal, and/or vigilance. And again, this is very much a spectrum, right? So you can have mild sedation, you can have moderate sedation, then very deep sedation, and then followed up by the kind of the general anesthesia. So again, it's all going to be kind of a spectrum, and patients can kind of vacillate between one stage to another depending on the dose of drug that you're giving them, the time frame that you're looking at. So timing of medications can be really important too, considering do you need repeat doses? Is this a quick procedure that I can do short-acting meds on, or is it going to be something that's going to be much longer that I'm going to need to either give a lot of doses or need to give longer-acting medications, right? So for instance, if you just did like a quick reduction versus with a cast of say like a forearm versus if you're having to do like a spica cast, right? So those things like take forever to do, and so that was one that you really require a lot of sedation for your patient to implement. So it's important to consider that amnesia is not going to be the same as analgesia, and oftentimes we're going to be shooting to achieve both for our patients, because obviously if they are, maybe they could be amnestic, maybe they are somewhat sedate, but they're still feeling pain, they can still have those responses to that, some of those reflexes. So we'd like to usually have a balanced approach to this where we provide both amnesia and analgesia. Okay, so again, we try to shoot for balanced anesthesia, so this is going to be that combination of inhaled plus IV agents, and basically this takes advantage of the pharmacokinetics and pharmacodynamic properties of each drug. The ideal anesthetic for our patients would be ones that induce a smooth and rapid loss of consciousness. They're going to allow for a prompt recovery after its administration is discontinued, so you want drugs that have a very fast onset and a very fast offset, right? Because the longer they take to recover, the longer they're in the PACU waiting to go to a room or wherever they happen to be going to. That's fewer patients you can cycle through, right? So a lot of it is a time component too, where you want your patients to recover quickly. You'd like to have a wide margin of safety, so we want drugs that have a very wide therapeutic index if possible, larger the better. And then obviously we'd like things to be devoid of adverse effects, but you're going to find that's not very possible in a lot of cases. But by using combinations of drugs, you can get away with having faster onset of things and hopefully quicker offset for some of these. So we'll look at the different drugs and how they kind of fill in these various roles here. So the choice of anesthetic obviously is going to vary. If you're doing, say, like a minor procedure, say you're just doing like a laceration repair or something, usually you can get away with oral or parenteral sedatives. This is where we use very frequently because, you know, kids getting IV access is pretty difficult in some cases. This is where we use a lot of intranasal administered midazolam, right? So that midazolam being what type of drug? Yeah, it's a benzodiazepine, right? So it's going to be affecting what neurotransmitter? GABA, yeah, GABA, right? So it's going to be affecting GABA. It's going to cause some of that sedative type of effect, and so it's able to allow our patients to kind of chill out a little bit, right? Oftentimes we'll use it also as an anxiolytic to try to help alleviate a lot of their stress that they're undergoing at that time. But intranasal, oral administered midazolam all can be very good. We'll also talk about our local anesthetics, and so these are going to be things like your lidocaines, your bupivacaines, and where that can kind of fill a role here as well. For more major procedure, this is where you're going to need certainly some preoperative benzodiazepines. That's going to kind of start off that kind of amnestic period to their anterior grade amnesia, and then we're going to introduce intravenous anesthetics, and then followed up by a combination of both intravenous and inhaled anesthetics at that point, right? So typically you start them off like in the pre-op area, giving them some benzos to try to calm them down, get them a little sleepy. Then you're going to roll them in. Provide them with either IV sedation and then start up the inhaled stuff as well, and that way they'll have a very nice balanced anesthesia, and then we'll look at the kinetics of that and how they kind of play a role with one another, but that's generally the kind of flow of things. So as far as general anesthesia goes, we'll look at both inhalational and intravenous agents. We'll start off with the inhalational ones, but again, these are going to be volatile liquids. Usually come in kind of pressurized cans, and they stay in the liquid state, and then they get hooked up to the specific, not nebulizers, but vaporizers, where they can be delivered into the patient. Most commonly, the ones you're going to see used, and we'll talk about these more in detail, but Isoflurane, Desflurane, and Sevoflurane are probably the most common ones I've seen used in the OR realm. And we'll also look at nitrous oxide, which, what else is that known by? Yeah, laughing gas, right? So again, we'll look at how nitrous oxide plays a role here, but in general, you're going to find that nitrous oxide is better for kind of minor procedures. It's not going to be able to induce a real good general anesthesia like you would see for something like, you know, Desflurane. We'll look at the kinetics and why that is as we go forward. As far as intravenous anesthetics go, we're going to look at drugs like our barbiturates. Can you guys think of any examples of those? Phenobarbital. We don't use phenobarbital quite so often. It's usually reserved more for seizures, but there's other ones like pentobarbital that you use more frequently. Secobarbital sometimes, so we'll look at those. Benzodiazepines, we've already kind of mentioned a few of those. Midazolam being a very common one in the surgery realm. Propofol. You guys know any famous people that had interactions with propofol? Michael Jackson, yep. So he unfortunately succumbed to too much propofol. We'll see some of the adverse effects you can have when you have too much of that. We'll talk about ketamine, Special K. It's one of my favorite drugs. You know, people usually get a little weirded out when I say that I like to give ketamine to little kids, but it's only in the clinical setting, okay? Only when they got broken bones and stuff. We'll talk about opioid analgesics, so you know a lot about those already, but we'll talk more about ones that are parenteral and ones that are very potent for in use in the surgical realm, and then we'll talk about some other miscellaneous drugs. And again, sometimes you'll either use these by themselves or you'll use combinations of drugs. So very frequently, especially for sedation, like say in the ICU for a ventilated patient, to provide both analgesia and sedation, we'll do something like a combination of say like fentanyl plus midazolam drips. So we'll actually give them continuous drips of both of those drugs because they provide kind of, midazolam providing sedation, the fentanyl providing more of the analgesia, and that way you get a balanced sedation for that patient. They don't really remember, and they're also not fighting the ventilator at that point. So you see how we can use these combinations to good effect later. Okay, so again, you'll find that typically the onset of action for a lot of the inhalational anesthetics is not super quick, and so generally what you're going to find is that the inhalational anesthetics are used for maintenance of anesthesia. They have a pretty good offset for the most part, so we'll usually kind of induct the patient or use these induction meds with IV analgesics usually, or some of these sedative agents, and so basically put them down with IV and then maintain them throughout the surgery or the procedure with inhalational drugs. And then also you can get away with using things like local anesthetics for blocks, epidurals, things like that can also help to provide some analgesia by kind of eliminating that sensation whatsoever. So again, what are some cases where you might use like, local blocks or spinal blocks? You guys know of any? Sutrane. Yep, Sutrane is a good one, so you can apply a local anesthetic there. Sometimes in a lot of like ortho cases, like if we were to have like say joint replacements, like knee replacements or hip replacements, you can actually do local blocks with basically have a continuous infusion of anesthetics like bupivacaine or something, and basically just have it just deaden all those nerves in the area. And the idea there is you actually limit a lot of the doses of other drugs you may have to use. So you actually limit a lot of the opioid use, which again in the post-op setting, what's a big problem using opioids? Constipation is a big thing, right? And you want their guts to usually wake up for the most part, especially that abdominal surgery. But using a lot of local anesthetics can actually limit the dose you need of opioids and help you to get away with less of that, better recovery time for your patients, and also less risk for things like addiction and whatnot. So all that can be very good as adjuvant drugs. So there's several stages of anesthesia. You guys are probably getting close to stage 3 right now. I've seen a little of the excitation, but so essentially we'll talk about the first stage being that of analgesia. There's going to be an excitation stage, and then you get to the stage of surgical anesthesia, which is usually the sweet spot for a lot of patients, and then we'll talk about this medullary depression. Usually don't want patients to get there necessarily, but you'll find that again every patient's a little different, and it's all a spectrum. My dad's a CRNA. He's actually been doing it for 20 some odd years, something like that. He was like one of the first like male, not the first male nurses, but it was at a time when male nurses were not a really big thing, and then having a CRNA at the time was odd. So he actually doesn't even have like a master's degree; like he only has like a bachelor's. So he always talks about he's kind of proud of that because he was so early. But anywho, basically when he was talking about his job, he says basically we're trying to get patients as close to death as possible. And then bring them right back out of it after the procedure's done. I always thought it was kind of cool, and so we'll look at some of the ways we can actually do that and with our different medications. So again, when you have this first state of analgesia, again the patient experiences analgesia. Typically, not a lot of amnesia associated with it during this stage. But as you get kind of deeper into stage 1, you're going to start to find that some of the amnesia started being produced here, right? So again, patients normally, especially if they're going for general anesthesia, don't stay too long in this stage. But this is where we're going to start to see some of the like the pre-op meds starting to kick in, like some of your oral Versed and things like that, as we're starting to really kind of kick off. Next, we'll talk about this stage of excitement. So again, why do you think there's an excitement stage after you have like initial analgesia, but before you get to really kind of sedate? So again, think about, I always go back to my example of alcohol. Imagine when you have 1 or 2 drinks, what kind of happens to your mood? Yeah, you have this lack of inhibition. You start to basically put the brakes on by enhancing GABA effect. You're kind of inhibiting these inhibitory kind of pathways, right? And so you're getting this initial excitation stage. This is again why we see kind of paradoxical reactions with benzos in certain small children, because again they are at a dose where they end up having loss of this inhibition. They get very excited, but again as you get to say 5 or 6 or 7 drinks, how does your mood change at that point? You get very sleepy, you get very sedate. So again, you can overcome that by again just kind of inhibiting all of those pathways from the GABA standpoint, and basically you can overcome that, but it's all a matter of dose essentially. So you can kind of just treat through it. But the patient can sometimes appear to be kind of delirious. They may be vocalizing things, but the patient is amnestic at this point, right? So they're probably not going to remember them, kind of freaking out, or if they're fighting, the staff or anything like that. You'll find that the respiratory rate, and we're going to look at a chart that kind of shows you how the respiratory drive changes throughout these different stages. Here it can be kind of irregular, both in volume and in rate, which for most patients probably should be sufficient. But again, you're going to be monitoring this. You're going to be looking at their pulse ox. You're going to be looking at their end-tidal CO2. Hopefully, if you have monitors that can do that. And then if the patient's stimulated, this is also where you're at running risk for retching and vomiting, right? And so if you have a patient who's kind of starting to get sedate and they throw up, what do you run the risk of? Aspiration, right? Then you worry about a chemical pneumonitis, and that's not really going to be good for your patient. So we don't want to have that occur. So this is where a lot of antiemetics can be very useful during this stage in order to help prevent them from vomiting. So efforts are generally made to limit the time that the patient spends in this stage, and so we try to get them through by using our induction agents that usually kick on very quickly. And then once you get past the stages, we're going to start to reestablish kind of normal, regular breathing pattern. So now when you get into stage 3, this is the surgical anesthesia. So again, you'll have a recurrence of regular respiration, and this is going to go basically from regular respiration all the way to complete apnea, right? So again, this is going to be the sweet spot for some patients. Usually going to be, we'll talk about different stages or four planes that you're going to find in stage 3. So stage 3 is kind of broken up into a few different planes, and you're going to look at that continuum and see how things change throughout that. And then finally, stage 4, this medullary depression. This is the deepest stage of anesthesia. Basically, you're having some very severe depression of the CNS, where you're having vasomotor center activity being inhibited. You're having the respiratory center and the brainstem being inhibited. And basically, without providing circulatory, respiratory support for these patients, they would basically just die because they're not breathing. They're not able really to oxygenate themselves very well. So we don't like to stay too long in this stage if we can help it. So it's kind of a good chart. I like to kind of show you the different stages of analgesia and anesthesia. Looking at respiration here, you can kind of see where, stage 1, yeah, it's pretty normal for the most part. It's a little more irregular during stage 2, during that excitement stage. And then as you get down to this first plane here, probably easier for using the laser pointer. Again, notice that it's going to be back to kind of normal in this first plane, but then as you go along, you're going to find that you're just having less respirations until the point where you get to total apnea, right? You can also look at things like how is ocular movement changing, how are the pupils, how are they responding to light, things like that. Muscle tone is also going to be going down pretty significantly during this stage 3, which we want. We want them to be very relaxed for the most part, so we can get into our procedure. Also, just response to painful stimuli should be going down here as well. So again, it's all going to be a continuum. Patients may kind of vacillate between one plane to another, and this is why it's so important that we have short-acting medications so that we can titrate very quickly, right? So very frequently you'll see like anesthesiologists when they're providing maintenance of anesthesia for these patients, they'll be dialing things back and forth. They may give a little bit more, and they'll look at their blood pressure, heart rate, if the patient's moving at all, they may dial it back, so it's very much they're kind of tinkering with things to make sure the patient's staying in a very good stage, but they can have some vacillation there. Again, just another chart to kind of give you some examples of how things change throughout the different stages here. Again, just with numbers as opposed to looking at it more graphically. So. Again, using the inhaled anesthetics, this is where we're delivering gases or vapors to the respiratory system in order to produce anesthesia. Remember that the lung vasculature is pretty vast and is a very good space for absorbing some medications. And so the way that we change our dose here is going to be based on the concentration of inhaled anesthetic in a mixture to oxygen, right, and to other gases that we're normally breathing in. And so we're going to be looking at the partial pressure or the tension of it. So the higher that is, the more gases we're providing, the higher percentage that they're inhaling, and that's the bigger dose they're going to be getting to the brain. You're going to find that drugs need to partition from the lungs and the alveoli over into the bloodstream. Right, so that's going to be one partition that has to occur in order to get the drug into the system, and then from there, from the bloodstream, where does it have to go to? What major barrier does it have to cross? Blood-brain barrier, right? So it has to get across that as well. So that's going to be kind of another partition coefficient that we're going to be looking at. So things that are able to cross into the bloodstream very easily and then cross the blood-brain barrier are going to have the fastest onset of action. But again, in most cases, you're going to find that the inhaled anesthetics aren't really fast enough for our purposes, and so this is why we use IV induction agents for the most part. But again, drugs with a low blood gas partition coefficient, they end up equilibrating more rapidly than those that have higher blood solubility. So again, because they're not able to really cross as well, they end up equilibrating and get your kind of steady state much more quickly. But if it's necessary for the anesthetics to achieve the brain concentration, again, they need to be able to cross that blood-brain barrier very easily. It's kind of a two-stage process, and we'll look at some of those differences there in just a few minutes. We look at the different drugs. So the rate at which you're going to be achieving that therapeutic concentration is going to be dependent on how fast you can get it to the brain, as I mentioned. So again, this is going to be a couple of different characteristics here that can influence this. So things like the solubility properties. So drugs that are going to be more fat soluble are going to cross these barriers more easily. So that can be one thing that helps to speed on the onset of action. The concentration of inspired air, so if you increase the concentration, you're going to have more of it partitioning over, because again, this is a passive diffusion kind of process, so the more drug you're inhaling, the more you're going to have into the system. The volume of pulmonary ventilation can be important as well, so if they're having less inspired air, and again, at this point, they're probably going to be intubated, so we can change ourselves by changing the ventilator settings. That will increase pulmonary ventilation, more drug gets absorbed. And then pulmonary blood flow. So again, less blood flow getting to the lungs. If they had something like pulmonary hypertension or some other comorbidity that prevented that, that would also see a slowed onset of action there. And then looking at the partial pressure gradient between the arterial and then mixed venous blood anesthetic concentration. So the higher the concentration is in the lungs, the more diffusion you're going to have into the bloodstream versus if it's kind of equilibrated at a point where it's kind of hit a steady state, so to speak. So just giving you some examples of the different solubility and looking at onset of action here, you can see to where on the left side here, so here you have the arterial anesthetic tension, or this is going to be the percent of the inspired tension here. So as that goes up, you can see how the solubility is going to be changing over time. So you can see something like nitrous oxide has a pretty steep dose response curve here, but at some point it's going to hit a kind of a plateau effect, right? At some point the bloodstream concentration is going to kind of equilibrate out with what's in the alveoli, and you're not going to have a lot of transfer at that point. So you end up kind of getting a steady state level here, and so that time to get to there can be affected by how much you're actually inspiring, what the pulmonary ventilation is going to be like, and whatnot. And so this is where you can have different characteristics for your inhaled anesthetics and how fast their onset is and how long they're going to last for. So how do these drugs specifically work? How do they induce their anesthesia? Well, most of it's going to be through GABA. So GABA is going to be one of the prominent receptors we're going to be looking at today, specifically the GABA-A. Do you guys remember what affects GABA-B? Any drugs that affect GABA-B? So we're going to see a lot of your skeletal muscle relaxants. So things like your tizanidines, your cyclobenzaprines, metolazone, things like, or not metolazone, Scalax and things like that. So those are going to be the main drugs that are going to be affecting GABA-B for the most part, skeletal muscle relaxants. But these are going to be affecting GABA-A, again, very similar to what your benzodiazepines are going to be affecting. And so because this is going to be the major inhibitory neurotransmitter, we're going to be affecting this, increasing transmission. And so this is going to be able to induce this nice state of anesthesia for our patients. So, and again, both are in IV agents for the most part. A lot of our sedatives are going to be affecting GABA. There's going to be some exceptions to that, but then the inhaled anesthetics are going to do this as well. So you can see where they're kind of working in tandem with one another. So some of the agents that we're going to be using most frequently as far as inhaled anesthetics go, and again, these are used in combination with IV in order to perform that balanced anesthesia. Nitrous oxide is going to be a good one for usually like procedural kind of sedations when you don't really need a deep state of anesthesia. This is going to be good for things like, if you're doing laceration repairs, or if you're doing reductions potentially as kind of an early kind of therapy there. The nice thing with nitrous oxide you're going to find is that it has a very quick recovery time, and so it can be very good in some cases where, especially if it's an outpatient office, if it's you're in ER, things like that. There's some ER programs that use nitrous oxide. It allows for kind of quick recovery of the patient. You can get them discharged more quickly, right? That's be one benefit there. Then you're going to have your more kind of general anesthetics, is where you see things like halothane, Enflurane, and then the three most frequent ones I mentioned are going to be the Iso, Sevo, and Desflurane. Okay. So, again, going back to that minimum alveolar anesthetic concentration, this is a good way that we can compare the different general anesthetics to one another. And so, looking at that potency by comparing that MAC 50. Basically, again, we don't want to achieve just a 50% rate of anesthesia for these drugs, but if you are able to get to about 1.3 times the MAC, that will end up capturing about 95% of those patients. So you really don't have to go much above that in order to help capture those additional patients. But again, you're going to find that different patients, based on their comorbidities, based on other things, you can actually find that they may be more or less resistant to these anesthetic effects from these drugs. So for instance, those that would have a decreased MAC, meaning that they need less drug in order to achieve anesthesia, are going to be those that typically have kind of less physiologic reserve. Things, like elderly patients tend to have a lower MAC, so they require less inhaled drug in order to get that anesthetic state. Hypothermia, for whatever reason, end up lowering your MAC as well. They really don't find that different genders, different heights, different weights really have any effect on the concentration. Everyone kind of is inspiring the same kind of air, and they're responding to it very similarly. So you don't really find like weight-based dosing for this sort of thing, right? But things that may affect and cause your MAC to go up, requiring you to use more, would be things like pregnancy can do this, alcohol abuse, or chronic use of centrally acting drugs. So these would be things like benzodiazepines or muscle relaxants. And why do you think alcohol and those CNS depressants would affect this? So think about it chronically, as you have patients who are abusing things like ethanol, and ethanol is affecting what neurotransmitter? GABA, right? So it's causing GABA to be overactive, and then as you're constantly activating those receptors, what do the receptors like to do? Downregulate, right? So at that point, you have less GABA receptors for the general anesthetic to really affect. So you can find those patients actually become more resistant. So you can see this with certainly chronic alcoholics who developed a lot of tolerance to the effects of alcohol. They may require much higher doses of their inhaled anesthetic in order to achieve that same amount of anesthesia, right? So MAC has gone up for those patients. And again, looking at kind of the range of effects you can see here. So again, you're going to have basically the number of responders here on the y-axis here, and you're going to have the MAC fraction on the x-axis here. Basically, you can see how things are going to be changing as time goes on. So things that have higher MACs are obviously going to be over here, kind of more to the right, where you need higher doses in order to achieve this effect, versus things that have a lower MAC are going to be more potent, thus they're going to be a little bit further on the left side here. But again, you're going to have different effects occurring at different percentages of that MAC. So again, you start off with the amnestic effects. As you get higher doses, you're going to see the unconsciousness kind of set in, and then finally immobility is where you have more of that relaxation and whatnot as you get to higher and higher doses. Right? So of course, this is kind of what we're achieving, or this is what we're hoping to achieve when we're doing general anesthesia, versus if you're using something like nitrous oxide just for a kind of a procedural kind of sedation, you may be focusing more here on the kind of amnestic side, right? And so we'll look at how the MAC kind of varies between these drugs, and you can see where nitrous oxide is going to be better for those kind of roles. So effects on the body you're going to see, we will look at the cardiovascular effects of these different drugs, and you can see they're actually going to differ a little bit based on whether or not they're going to be increasing cardiovascular activity, if they're decreasing it. So we'll look at that as it varies between the different drugs. In general, how these drugs affect the respiratory drives, they're going to cause respiratory depression and usually decrease mucociliary function. So again, you worry about secretions and things like that not being cleared for these patients, which is why we'll look at some drugs you can actually use to help with that. As far as cerebrovascular, you're going to be seeing decreased metabolic rate, which can be good for patients with head traumas or things like that, where that can be beneficial. And then typically you're going to find diminished renal and hepatic blood flow. Again, these are all going to be transient effects while the drug is actually being administered. Typically things go back to normal as soon as you kind of pull them off. So the first one we'll talk about is going to be halothane or fluothane. This is an older drug. We don't use it clinically all that too often, but it's a very potent anesthetic agent, again, working by activating those GABA A receptors to increase the permeability of chloride, hyperpolarize those nerves, and prevent those action potentials from occurring. We'll look at the difference in the onset and the recovery, but again, these are usually drugs we want to have fast onset and fast offset as much as possible. So things that stick around for very long periods of time, we don't really like it quite so much from these inhaled anesthetics. You're going to find that this one is going to be lacking analgesic potency, which means you oftentimes need to use it either with another anesthetic, or you're using it combining with another type IV agent in order to provide the analgesic effect. So this is where things like thiopental, which is another barbiturate you might be using, I'll talk about later, nitrous oxide, muscle relaxants can all be useful as kind of adjuvant drugs here. Has a pleasant odor, which is going to be kind of a good thing for some patients. And then most of these drugs just end up getting eliminated in the exhaled gas. You may have some small amount of metabolism that occurs, but for the most part, they're just going to get expelled in the respiratory tract. Next, you have Enflurane or Ethrane. This one's going to be a little less potent than halothane is, and I'll show you a chart just to kind of compare these in a few minutes. Again, you're going to have a medium rate of onset and recovery, but typically has a little bit more rapid onset than you would see with halothane. And so it's not uncommon. You might find, especially the vaporizers that the anesthesiologists are using, you'll find that they're going to have different gases hooked up at the same time, and so they can use one for induction or one early on, and then one maybe better for maintenance, right? And so you may be switching those out depending on what the patient's doing, what their vitals look like, and etc. Also, faster awakenings is going to be another reason why Enflurane might be better than halothane from that standpoint, and also some more skeletal muscle relaxant effects. Okay, so you can see how these are going to have a little bit different profiles and why you might prefer one versus another. Again, very similar effects to what you see with the halothane, but here you can notice you can see hypotension associated with this. So it might be a case where you want to be watching your patients, make sure they're they have fluids, make sure they may not need pressors potentially. So it's not uncommon. We'll have some of our anesthesiologists will have doses of epinephrine ready to go, so they can give that to the patients to try to perk up their blood pressure a little bit. So it can be a very common drug to see used there. And then getting into the ones that we use much more commonly, so the big three. So there's Isoflurane or Forane. I'll never forget this drug because, again, I said my dad was a CRNA, and back when we had the internet, when it was first coming out, and you had to pay like per minute on the old like 56K modem. Anyone remember that? You guys are far too young for that for the most part. But yeah, so we had to pay for every single minute, you know, when it's on that phone line. But essentially, that was his password for the internet, and I'll never forget that. I was like, "What's Forane?" It's a weird password, but now I know. Anywho, my dad was really into anesthetic drugs. So that's what it was. So again, isoflurane, you're going to see better kind of muscle relaxant effects here, which again gets the patient in a better state for surgery. It's going to have medium onset and recovery. And typically this one's kind of surpassed halothane and Enflurane because it offers more rapid induction. So this is going to be better for making sure the patient is in a good anesthetic state. And then you typically see faster awakening. So you can see why this one's going to be a little bit better preferred. Again, your patient's going to wake up sooner. They're going to get out of the PACU sooner, hopefully, than if you're using some of these longer acting drugs. And so nice thing here is you're also going to have very little post-anesthetic organ toxicity. We'll talk about some other side effects, but you low risk for seizures, which is going to be a good thing, and also doesn't induce any arrhythmias, right? We'll look at that a little bit later. But one of the things you worry about with using some of these hydrocarbons is that they can sensitize the heart to, especially if you have any like halogens on these hydrocarbons, so think like halothane, you can end up having sensitization of the heart to catecholamines especially, and so you worry about arrhythmias. But nice thing with isoflurane is you kind of bypass that. Again, you're going to expect to see respiratory depression, which you can certainly expect, but this one actually causes increased cardiac output. This can be maybe better for some of your CHF patients. This might be a better anesthetic to use for them. May see hypotension associated with it as well. Next, you have Desflurane or Suprane. We will see this one used very frequently in sometimes emergency type settings, sometimes in outpatient surgery. You'll see this one being used. Has pretty poor induction properties, has low volatility, so it's hard for it to really get into the system and causes anesthesia. But it is, once you have anesthesia induced, this is a good kind of maintenance drug for that. And also it's a very fast recovery, so this may be something where you induct the patient on, say, isoflurane, and then switch them over to Desflurane. So that way, when they're done with the procedure and they're trying to wake them up, they wake up much more quickly from this drug. Okay. Here you can see some myocardial depression, so you may actually see decreases in cardiac output. You can also see some coronary and cerebral artery dilation, which may or may not be problematic for your patients if you're worried about things like, if they had a stroke recently, you may not want to increase that cerebral blood flow potentially. And also you run the risk of having laryngospasm. So you guys know what that is? Yeah, basically everything is just kind of spasming up here in the larynx, and so that can be problematic when you're trying to oxygenate your patient. So say, for instance, you've extubated the patient, and all of a sudden they spasm up, and now they're not able to oxygenate, and then now it's really difficult to intubate them, right? So that can be a really big problem that you worry about. And so we actually have laryngospasm kits that we keep in the OR for just such a case, right? So it actually includes a sedative agent. We'll talk about propofol a little bit later on. So our kits at Nemours include propofol, and also a drug called rocuronium, which is a paralytic drug. We'll talk about paralytics probably in the emergency section, but basically by giving a paralytic, you can loosen up that muscle and allow the patient to be intubated again, or at least to be able to oxygenate them, because otherwise what's the alternative? How do you get an airway at that point? Yeah, you got to cric them in. So we don't want to do that for our patients, especially if they're going in for some, they're going in for an appendectomy or something, and all of a sudden they have a cric. That's probably not what they want to wake up to. So again, laryngospasm is a very, it's not a super common occurrence, but it's something you want to be prepared for in case it occurs. So we'll talk a little bit about that later. And then you have Sevoflurane or Ultrane. This one is pretty rapid onset and recovery. Again, this one you can end up seeing some nausea, vomiting, some agitation, especially when they're waking up, and then bradyarrhythmias and hypotension here. So again, this would be not great for a patient that maybe is more required or more reliant on their cardiac output to maintain oxygenation. And then potentially also you have bradyarrhythmia, but they can have tachyarrhythmias too, and that goes back to that kind of sensitization of the myocardium to catecholamines and whatnot. So, and then nitrous oxide. So this one is getting a lot of use, especially in outpatient settings. Again, otherwise known as laughing gas. You guys seen the movie Black Sheep? Had the nitrous in the police car and it gets leaked out. You should go look that up. It's very funny. But anyway, the nice thing here, it's odorless. It works fairly well for getting kind of minor procedures done because it provides kind of a nice light kind of sedation in a lot of cases. So it's good for like dental procedures. You can use it as a supplement to kind of bridge you to other drugs. So I remember when I was a child getting my wisdom teeth taken out, they started me off on nitrous oxide, and I think they switched me over to propofol or something. I think I remember some kind of white milky substance. So I'm assuming that's what it was. So again, it can be a good supplement until you can bridge them over to something else. I remember when I was getting the nitrous oxide, how they were determining whether or not the drug was working, and they did it by saying, hey, you know, as Panda walked into a restaurant and got a meal, and then when the waiter brought him his check, he took out a pistol, shot the waiter, and left. And the guy at the bar said, well, why'd the panda do that? And the bartender says, go look up panda in the dictionary. And it says, eats, shoots, leaves. So I laughed hysterically, and they knew the drug was working. So, again, so there are different signs you can look for to see whether or not your drug's really kicking in or not, and that could be one that you do for your patients on nitrous oxide. So again, this is oftentimes not going to be effective as a single agent because, again, it's very, very light, and we'll look at the different kinetic profiles, and then we'll see why that is in just a few minutes. And again, primarily going to be expired in the respiratory tract, so you don't really worry about a lot of metabolism from that standpoint. So, other effects you can see with nitrous oxide, you can see increases in blood pressure, so hypertension is a possibility, and then you also run the risk of having this expansion of the gas volume in different air cavities. So this is going to be for patients who are maybe getting higher doses or they're getting it for a long period of time. So you can see things like distension in the bowel, you can have rupture of the tympanic membrane, pneumothorax. So again, rare side effects, but something you do want to be careful of, especially with the longer the patient's getting, the more likely you are to see that expansion occur from that standpoint. And you do also see a lot of high incidence in post-operative nausea, vomiting, so you definitely want to supplement with some Zoflurane or something like that to prevent that from occurring. As far as contraindications go, you do want to avoid this for pregnant women, immunosuppressed patients, and also patients with pernicious anemia, because this actually can cause, and this is actually something you see if you're looking at like patient or healthcare workers who divert medications. Who do you think is most likely to do that? What type of healthcare provider? You look at the numbers, so like diverting, like, you know, using drugs for themselves instead of the patients, right? Usually anesthesia is one of the big things there. So they're at high risk for substance abuse because they're around those drugs all the time. They have easy access to it. But this is a big thing where they were seeing a lot of anesthesiologists or CRNAs or other anesthesia providers who were using nitrous oxide kind of just for fun. And so they actually ended up developing these B12 deficiencies, and they ended up getting like these neuropathies and anemias. So if you were to see something like that, it could be related back to, you know, abuse of nitrous oxide. So very kind of odd things you can find with odd uses of some of these drugs. Because again, this won't be a problem for most patients, because if they get it as a one-time outpatient procedure, it's not going to be a big deal. But if you're constantly using it, again, this is where you see some of these problems crop up. I'm not saying all anesthesia providers are drug diverters, but I'm just saying that's if the people are, the numbers bear out, that's usually one of the high-risk healthcare provider populations, right? So. Anyway, looking at a comparison between the different products, so you have your nitrous oxide up here on the left. The nitrous oxide here, they have your Desflurane, Sevo, and Isoflurane. So we'll kind of focus on these most. You can see what their blood to gas partition coefficient is going to be, and this is again going to be dictating how easy it is for these drugs to get from the alveoli to the bloodstream, and from the bloodstream into the brain. So you don't need to memorize any of these numbers, obviously, but if you're looking at the mean alveolar concentration, this is the thing I do want to focus on here in looking at a comparison between the different drugs. So again, higher doses needed to induce that state of anesthesia for 50% of your patients. And if you notice, looking at nitrous oxide, you require massive, massive doses in order to get to a state of anesthesia. At that point, you're not giving them any oxygen, and so that would be bad, right? So this is why this is better for just really kind of light sedation. As compared to things like Desflurane, Sevoflurane, you can see how this starts to drop pretty significantly, and there's going to be much more potent agents. So Isoflurane probably being the most potent out of the group of those three.
The concentration is in what kind of units are we looking at?
I don't know off the top of my head. It's probably like parts per million or something like that. I should probably include units because I gripe about that for a lot of people not doing that. So shame on me, but yes, you should. You can look that up though. It's probably parts per million if I had to guess. Again, notice not a ton of metabolism happening here, and so a lot of it's going to be just expired in the respiratory tract. But again, look at the Sevoflurane. Notice it has some fluoride here. This is what that halogenated hydrocarbon is. That's the thing that's sensitizing the myocardium to catecholamines. That's where you can see the arrhythmias start to pop up from there. Again, that's the same reason why you have patients that are huffing things like Forane or things like that. That's why they end up having ventricular arrhythmias, is due to that same kind of effect there. Because again, when you're huffing Forane, you're almost getting the same kind of anesthetic effect as you would see with some of these drugs as well, right? Because the principles are essentially the same. I do not recommend huffing Forane though. It's pretty bad. Get frostbite all down your throat. It's no good. So here's a good table to kind of compare the cardiovascular effects. So again, in general, you're going to find hypotension being most common with these drugs. For the most part, you're going to find drops in their MAP. So it's pretty consistent there. But again, some of these you're going to find, you know, it's going to vary. You see decreased cardiac output, decrease in their systemic vascular resistance, and then looking at the differences in heart rate. See with like Desflurane, Isoflurane, typically going to see bumps in their heart rate, whereas they're going to have a drop in their blood pressure. So you know, again, these are things that the anesthesia providers are watching constantly. They're always, and if you look at their software that they ever, if you like get on rotations, their software usually, if it's sophisticated, is going to be monitoring and recording the patient's vital signs like every few seconds, right? Because they want to be monitoring this constantly to look for any kind of changes, any kind of warning signs that they need to change, dial back their doses, or give more, give less, or whatever it happens to be, and they'll have it all related back to the vital signs. So looking at the toxicity, we're going to talk about the potential for hepatotoxicity, some nephrotoxicity, and the malignant hyperthermia. We'll talk more about that in detail. Yeah, we'll just keep going with that for right now. Malignant hyperthermia, have you guys heard of this before? Your cousin's had it? Oh, no, that's not good. It's a rare thing that happens, but essentially what you'll end up seeing is that a patient will be under general anesthesia. They will be doing their thing, and then all of a sudden they will start to have, you know, if you're monitoring for end-tidal CO2, you're starting to see the CO2 go up. And if you're monitoring their temperature, temperatures are going to start to go up. And the patient is going to look like they're very rigid for the most part. So it's a rare thing. It's a autosomal dominant genetic disorder. So again, this is why we always ask before patients get anesthesia, have you had any family members who've had a bad reaction to this? Because that would mean that you're maybe more likely to have that same mutation, okay? But it can cause significant morbidity and mortality if it's not caught early, because again, when you are becoming more rigid, the muscles are starting to bind up. They're causing a lot of heat to be produced, a lot of acids being produced. Patients get very acidotic. You can see rhabdo develop here. So it can be very, very deadly if you don't catch it early, okay? So again, you're going to see this more likely to occur in patients who are getting general anesthesia with these inhaled anesthetics. And there's also a neuromuscular blocker called succinylcholine that is also likely to cause it as well. Okay, so succinylcholine is a very common drug we use in rapid sequence intubation, and so that'll be another one where we'll mention malignant hyperthermia there. So very frequently we'll have malignant hyperthermia carts that we keep in hospitals. Usually we're going to have one in the OR and then one in the ER, because those are the two places you're going to use those drugs most likely, right? Basically, the patients are going to have this mutation, the ryanodine receptor, which, and I'll show you a picture in a second, but essentially their sarcoplasmic reticulum just releases way too much calcium and causes way too much muscle binding or muscle contractions. So you can do genetic testing potentially, but it's really kind of too early for this to be a common routine thing to check patients for. But this is why it's so important that we do good histories beforehand to see if they're at risk for having a bad reaction. So here, if you imagine here being a myocyte, normally calcium comes into the cell to stimulate your sarcoplasmic reticulum, which will end up releasing more calcium from here, causing the contraction to occur. Basically, they have a modified ryanodine receptor that becomes more sensitive when they have these general anesthetics or succinylcholine on board, and it will cause way too much calcium to be released, end up causing way too much contraction, and then you get the problems, right? So they get hyperthermic, they get acidotic, and they get very rigid. So very rapid onset, so you're going to see tachycardia, hypertension start to develop. You can see hyperkalemia develop. These acid-base disturbances happen here. The main treatment is going to be kind of a multi-phase kind of thing. So one, you want to get them cooled. So we oftentimes, our malignant hyperthermia cart actually has like a small fridge in it, and it has a lot of several liters of saline already in there, kept at a cool temperature. We can infuse into the patient. We also will have multiple vials of sodium bicarbonate, because that's going to help to alkalize the blood and get them back to a normal pH. And then we have this new drug called dantrolene. I mentioned this previously when we talked about neuroleptic malignant syndrome seen with what type of drugs? Yeah, antipsychotics like haloperidol and flufenazine, the high potency D2 blockers. Neuroleptic malignant syndrome can look very similar to malignant hyperthermia. It's just this one is like in the setting of usually surgery. Usually it comes on very rapid. But by giving dantrolene, we can it works as a peripheral muscle relaxant, allows the muscles to relax, and you stop that generation of heat and acids. So it's a very important drug to make sure you have on board or have on hand if a patient does end up developing this. And again, it's not something very common. We don't run into it very frequently, but when it does happen, you want to be prepared for it. Okay, so key points here. Inhaled anesthetics are going to have good amnestic effects. For the most part, they have quick offset, which again is good for recovery for our patients. And they're going to be very additive, providing sedation to IV anesthetics. So generally, you induct them with IV anesthetics, switch them over to inhaled for maintenance of anesthesia. Again, based on the solubility, the more soluble the drug is, the more likely it's going to have a fast onset and a fast offset. So we kind of looked at that when we were looking at the comparison chart there. As far as monitoring goes, look for malignant hyperthermia, look for that increase in heart rate, blood pressure, their temperature, all of that. And then again, be careful with the post-op nausea, vomiting. Most of your order sets are going to have that already built in, so you're going to have as needed doses of Zoflurane already on the profile in case that occurs. Any questions from the first half? You guys are all very well anesthetized now? Comfortably numb for the Pink Floyd fans? Okay. Next we're going to be looking at the IV anesthetic agents. Again, these are very good for inducing general anesthesia. You can sometimes get away with using these for monotherapy if you're doing kind of more minor procedures in a lot of cases. For instance, like I mentioned, we use ketamine monotherapy in a lot of our fracture reductions and some of the more kind of in-depth kind of laceration repairs and things like that. Like just the other day we had, he was probably 15 months old and was running and ended up like slamming himself into a wall, had really bad ear laceration, which he needed to repair, so that required ketamine to keep the kid, calm and not moving. So again, you can use these as monotherapy. Or adjuncts to the inhaled anesthetics for more kind of like general surgery type things. Typically, they're going to have faster onset of action by the IV route than you would see with the inhaled anesthetics. And you're going to find that a lot of them are going to lack analgesic properties. So when I mention one that has analgesic properties, like make note of that because that'll be important because those are more likely to be ones that you can use as monotherapy. And then looking at the recovery time, this is very much going to be dependent on the drug and on the dose that you're administering. So say, for instance, this is a good example of this. So ketamine, as I mentioned, is what I have probably the most experience with as far as procedural sedation goes. Usually you do a dose of 1 milligram per kilogram for patients, right? It's kind of a standard kind of sedation dose you would do if you're reducing a fracture or fixing a lac, whatever it happens to be. So that didn't matter whether it was a 10 kilogram child coming in or if it was a 100 kilogram football player. We're going to give 1 milligram per kilogram to everybody, right? And so those big giant football players, they would end up getting, because again, we're close to Disney, so we have the sports complex, so you get a lot of like tournaments and things that are happening. So we end up getting a lot of like kids in the summertime for those kind of injuries. That and cheerleaders, but you end up seeing these big kids who end up getting full doses of ketamine, and they would be out for like 3 hours, right? And so when they're sitting there trying to recover in your ED, and you got more patients you need to see, that can be problematic, right? So we end up doing something where we're looking at the literature, and they actually found where you can cap out your doses, say like 50 milligrams, and then one of those things you'll find with these sedative drugs is that you can always give more. You can't take it back once you've given it in a lot of cases, right? There's very few antidotal agents that you'll find that we have for these drugs. We'll mention them where they come up, but for the most part, you have to just give them time for the drugs to wear off. And so what we end up doing is we actually found that if you cap off your dose at 50, the patients generally are still going to be pretty well sedate, and they also recover much more quickly. So we end up doing that for a lot of our patients where it's 1 mg per kilo up to 50, and then after that point, if you need to give supplemental doses, you can. So again, recovery times are very much going to be dose dependent, and also a little bit dependent on the patient, kind of what else they got. So big ones you're going to use here include the barbiturates. Thiopental is going to be a big one you can use in the surgical setting. We're talking about benzos, opioids, propofol, etomidate, and then ketamine are the main ones we're going to discuss today. So looking at the barbiturates, again, thiopental, phenobarb, pentobarb are the main ones you're going to see being used as sedative agents. Again, they're binding to the GABA receptor, and so similar to how the benzodiazepines work, they're all increasing GABA activity, but these guys are opening up those channels directly as opposed to the benzos are just working to let GABA work better, right? So you're going to find that these are going to be more sedating than the benzos are going to be. They're more likely to cause respiratory depression, and they're more likely to cause hypotension as well, right? So just think about these as a lot kind of stronger varieties of benzos and a lot more side effects associated with that. But they're good for treating seizures. They're good if you have like cerebral edema after a head trauma, lowering ICP. Not in the same clown posse, but the intracranial pressure, right? See if anyone's awake. If they're all still anesthetized. But you can use these as good induction agents for the most part. But again, they're going to lack analgesic activity, okay? So just good for sedative effects, good for amnestic effects, but the patient can still feel pain. Again, decreases in blood pressure, cardiac output, and intracranial pressure all going to occur when barbiturates being given. Thiopental, again, commonly used for anesthesia induction. I don't know how frequent I've seen it, at least in pediatrics, so you may see it, your mileage may vary with how often you're going to see this one. But it crosses that blood-brain barrier very quickly, so that's why you see quick onset of action with this drug. It's going to provide loss of consciousness, because it's a short-acting drug, usually for a short period of time, patients can recover pretty quickly from that standpoint. This is one of those cases where, and I should have put nitrous, so that's actually a good point. I made a grave error there. Nitrous oxide and nitric oxide are not the same thing. Nitrous oxide is the laughing gas, right? So you give that in conjunction with the barbiturates, you can kind of lower your doses of each that you need. Nitric oxide is something different. They actually use that in the ICUs in order to lower pulmonary hypertension. They'll use it to dilate the pulmonary arteries. So very different drug, but just keep in mind it's nitrous oxide, not nitric, and I'll correct that on the slide. Anywho, but again, the barbiturates are going to be potent respiratory depressants, but this could also be a very good drug to use for patients with intracranial or cerebral swelling, because it can help to lower the ICP. So this can be a good drug where, say you're like inducting them for either surgery, if you're trying to intubate them, this could be a good drug from that standpoint. Next are the benzodiazepines, and so these are going to be good for providing sedative, anxiolytic, and amnestic properties, but note they're not going to cause any analgesia. Okay, so very frequently, if you have a patient who came in with, say, like a displaced fracture, and they're waiting to get the reduction done, we will oftentimes give them, say, like an intranasal dose of midazolam as an anxiolytic, but we'll also give them, say, like an intranasal dose of fentanyl that is able to provide analgesia as well, right? So you always want to consider whether or not you need to add on an analgesic drug. But this can help to control acute agitation, so you see this being given very frequently in the pre-op setting in order to help calm patients down. We give this a lot in order to chill patients out so they can get IVs placed if they're very kind of ramped up about it, because again, it can be kind of a traumatic kind of procedure, and if they forget about it, that's great. So that can be a good place to use these drugs in conjunction with normal seizures and anxiety. Again, you're going to have a little bit slower onset of the CNS depressant effects than you do the barbiturates, but still they work pretty well. And oftentimes you're not going to use these as monotherapy. If it's just as an anxiolytic, you can get away with monotherapy, but if you need, like, better sedative properties, or if you need more analgesic stuff, you're going to use other drugs in conjunction with these. The most frequent ones we use are going to be diazepam, lorazepam, and midazolam. Again, these are the ones that are most commonly encountered in the IV form, and so midazolam is probably the most frequent one when they use in the surgical type setting or procedural type setting. Has a very quick onset and has a relatively decent duration of action, so you're going to find your patients are going to be sedate for at least an hour or two after a single dose, and so that can be good for most purposes. So again, nice thing here, high incidence of amnesia, so hopefully they don't remember a lot of what's going on here, and as a pretty steep dose response curve. So again, if your patients don't respond, say, to the first dose that you give, and try another half dose and see how they respond to that, and usually you'll get the kind of sedation or the anxiolysis that you're looking for. But this one's nice because we do give it intranasally very frequently, so it's good if they have no IV access. The antidote to benzodiazepines is going to be flumazenil, otherwise known as Ramazicon. And so this one is a drug that we don't use a lot for, say, like intentional overdoses, because of some issues with that. But this is a nice one to give in the surgical setting. So especially if you, say, gave too much midazolam and you oversedated your patient, you could reverse them with this drug. Or if you're trying to hasten their recovery, say after surgery, they're still kind of zonked out, you can give them flumazenil, try to wake them up a little bit sooner. Basically, this is blocking the benzodiazepines at their receptor site on the GABA channel, and basically just it's a competitive antagonist type of effect. So it's kind of kicking the benzos off in order to reestablish kind of wakefulness and return to consciousness. It's a relatively short duration of action, so you may need to redose your patients depending on what the situation is. So if you give it to them, they wake up and then they start to resedate, say an hour and a half later, you may need to give them another dose just to kind of keep them awake. Yeah, so you probably see this more frequently in the surgical setting. Just use it for, say, iatrogenic sedation due to benzos, or for to hasten recovery is the most common place I see this being used. Is withdrawal from benzos ever a problem? Yes. Okay. So again, remember when we were talking about that, how you develop tolerance to the effects of benzos. So you want to be careful for patients who are on benzos chronically, because you worry about if you kick this effect, or if you use flumazenil and you reverse the effects of those benzos and you put them into withdrawal. What's kind of the big thing we're worried about? seizures, right? Because if you block the GABA effects, and they've been dependent on those benzos in order to prevent seizures, or that's their new baseline. If you reverse that effect, you can see withdrawal seizures, and that's a big thing we worry about. So be careful for patients who are on chronic benzos. You want to try to avoid using Romazicon for them. But if it's a patient who is normally not on benzos, if it's a pediatric patient or someone who's benzo naive, this is a great drug for them because it can reverse the effects very well. Next, we'll look at the opioid analgesics. And so, again, high doses of potent opioids have actually been associated with some adverse effects. So we can see things like more post-op recall. We can have awareness during anesthesia, which obviously is kind of a nightmare. Like no one would ever want to be in that situation. Other problems you can see with giving, you guys remember the drug fentanyl? Right, it's a drug we sometimes give transdermally. Also, we give it very frequently in the surgical setting. But this can actually, if you give big doses too quickly, it can actually cause chest wall rigidity, and so you can actually end up impairing oxygenation from that standpoint. So that can be a tough thing, or one thing you want to avoid. And they also see increased post-op morbidity. So things like prolonged ventilatory support, GI and bladder complications. Because you mentioned what do opioids do to the GI tract? Constipate, they slow everything down. So again, this kind of prolongs the recovery period. So in order to avoid that, this is why we use other drugs in conjunction with opioids in order to help to lower those doses. The opioid sparing effect that we're looking for. So other things we can do to help limit the doses of opioids the patients receiving is also by giving them via the epidural or the subarachnoid route, most often the epidural route. So again, very frequently you'll see like the epidurals being given, let's say during labor, include ropivacaine, which is a local anesthetic, and then also fentanyl is a very common one. Again, because you're giving it just in the epidural space, it's limiting the systemic effects you're going to be experiencing with that, but still getting the anesthesia that you need. But we always try to limit the doses of opioids that we use as much as possible, which is why you see a lot of IV acetaminophen being given post-operatively, because it's actually been found to limit the number of doses of opioids that patients receive in the post-op setting, right? So anything we can do to limit the opioids they're receiving, hasten recovery, is going to be better for our patients. So the fentanyls are going to be the big ones we see being used here. So we talk about fentanyl and his brothers and sisters. So Remy, Al, and then Sue are going to be the big ones you see used in the surgical setting. That was a joke my dad made up, so if you couldn't tell that I'm his son. That's it. So again, these are good adjunctive agents. You're going to see these being used for induction of anesthesia in addition to a lot of the inhaled anesthetics. We use fentanyl very frequently in the emergency department for especially intranasal use. That can be a very good route if you don't have IV access. It's a very good, it's very short acting. So if you have IV access, in a lot of cases like in the ED, we might give morphine instead. That will have a little bit longer duration of action. But if you have an allergy to morphine, or if you get really bad pruritus associated with the histamine effects, like fentanyl is a very good option to use for a lot of them. So fentanyl is probably the second most common opioid we use, probably at least in the peds ED. With Remy and alfentanyl, you're going to see pretty rapid onset of action, and again, also used for co-induction of sedation. Other ones you may be seeing used is probably morphine most commonly, just as just for general pain. You're not going to see this in the surgical setting so often because it does have a longer duration of action. Again, in surgery, we like things that have a fast onset and a fast offset, and this is where the fentanyls really come into place, where they're going to be best used. There's also other, interestingly enough, I teach another class called Drugs and Society for the pharmacy school, and we actually brought in a SWAT team member from Orange County Sheriff's Department to come in and actually talk to us about some of the things that they're seeing. And one of the big issues they're running into is we used to be a big kind of pill mill state, right, where you go and get illegitimate scripts for like hundreds of oxycodone and things. We shut down on a lot of those, and so nowadays heroin is starting to become more common. Okay, so heroin obviously being an opioid drug. What they're actually finding is that their opioid, the heroin is actually being laced with something called carfentanil, which is another derivative of one of these, and it's like 1,000 times more potent, because you remember the dose comparison between morphine to fentanyl, like milligrams of morphine versus micrograms of fentanyl. So it's a very, very potent drug, and so a lot of the patients, or a lot of these drug users, would be taking a dose of heroin thinking that they would get their normal effect, didn't realize it had the carfentanil in it, and end up, basically what happens if you get too much opioid effect. stop breathing, right? So they stop breathing, they became apneic, and then they die, right? So that's one of the big problems we're actually seeing out there in the real world is some of these drugs being laced with things they're not, basically getting more than what they bargained for. So that can be pretty problematic, but it's a derivative of some of these other fentanyl-based drugs. And again, remember these fentanyl itself is a synthetic opioid, which means that it doesn't actually look like the chemical structure for codeine or heroin or morphine. And so because of that, if a patient has a morphine allergy, they're safe to get something like fentanyl. There's very low cross-reactivity between those two classes of drugs, right? Okay. You guys remember what the antidote to too much opioid effect is? Yeah, naloxone or Narcan, right? That's another competitive antagonist. Do I worry about withdrawal from opioids for some of those patients if I give Narcan? Is it deadly? Not deadly, right? So you're not going to see withdrawal seizures from giving too much Narcan, but certainly if you're on opioids chronically, and again, we're in the midst of an opioid epidemic, so a lot of patients are on these drugs chronically. If you give them too much Narcan, you worry about putting them into withdrawal. They're going to be throwing up, they're going to have diarrhea, they're going to be really mad at you, they're not going to be feeling very good. So that's one thing you do want to avoid, making too much Narcan.
The dose to the Narcan is related to how much they took?
A lot of it's related to how much they took. It could be related to the actual drug itself. So some drugs bind with greater affinity than others. So say, for instance, if I have something like heroin, very responsive to Narcan. I can give, if you look at, especially like places like New York, where they have a lot more heroin use than they did down here for a while, they'll give micrograms of naloxone just to make sure the patient's breathing, right? Just make sure they're blowing off CO2. Here, where we had things like buprenorphine, like Suboxone, usually used for opioid addiction, we'd have to give like 4, 6, 10 milligrams of Narcan before we'd really see a response to it, because it binds so tight to that receptor. It's very difficult for Narcan to really come in and displace it. Yep, so all dependent on the dose and dependent on the drug. Yep. Probably talk about that for like another hour, but I will spare you guys that, otherwise you will be asleep. Next is going to be propofol or Diprivan. This one works pretty similarly to the IV barbiturates, but has a more rapid onset, and so this is very good for not only helping to induce general anesthesia. We use it a lot for kind of one-time doses for procedural sedation. So say if you have like a dislocated joint, this is very good for adults to reduce those down. We will use this for continuous infusion to sedate patients who are ventilated. So very, I mentioned previously, patients who are intubated, we'll put them on fentanyl and Versed drips usually in order to help maintain that as a sedative and an analgesic. Here, most frequently, or more often than not, you can use propofol by itself as a very good sedative agent. So sometimes you'll see that to help maintain those patients. So if you're ever in the ICU and see what looks like milk running through the IV, it's probably most likely going to be propofol they're using to sedate those patients. But again, very good to use for adult patients, and we'll talk about those why that is in just a few minutes. But here we're going to see it's working as a GABA-A receptor agonist. Clinically, you can use it either for IV sedation in the operating room, procedural sedation, or for the sedation in ICU patients. Be aware, though, that you can see some problems if you're giving the drug at high doses for long periods of time. Essentially, what you can see is that they get this PRIS effect that happens here. It's this propofol-related infusion syndrome, where basically if you're monitoring the patient, they start to become acidotic. It looks like they're getting more sick than they were when they came in, oftentimes related to too much propofol is being infused for those patients. Also, and again, what does propofol look like? Looks like milk basically, but again, it's the drug has to be solubilized in this lipid emulsion, and so you can actually see hypertriglyceridemia from that. So their triglycerides will rise if you're on a continuous infusion for a long period of time. One-time doses usually not going to really run into that problem. One thing, again, I always point out when things can change the color of your poo or your urine, but this can actually cause green urine. So if you ever see an ICU patient who's been on long-term propofol infusions, you can actually see the urine turn green like that. So it could be, it's not any bad infection or anything, it's just the way the drug works. As it happens to be. Other big things you worry about here is the side effects with it are going to be hypotension is a big one. Obviously, it's going to be hitting your respiratory drive, so especially if you give too big of a dose or you give multiple doses, you can see apnea develop potentially, and then some pain at the injection site. But you know, again, if you're using this for short-term sedation, say for like a procedure in the ER, you can give just a one-time dose, and generally they're going to maintain the respiratory drive. You just don't have to really worry about that so much. It's when you have to give multiple doses where you can run into problems. The other big thing, and I always kind of harp on this is when I'm ever in the ICUs, is you'll have a patient who is coming in for sepsis, they got intubated in the ED, and now they're on propofol for sedation, and they're on like 3 or 4 different pressors, right? So they're on norepinephrine, they're on dopamine, they're on epinephrine, and they're like, oh, we just can't get this blood pressure under control. And I go, it's probably because they're on way too much propofol. And they're like, oh, you think so? And so they switch them over to fentanyl Versed, which has very minimal effects on the blood pressure, and all of a sudden they get them off all the pressors, right? So be very careful with propofol. It does absolutely cause hypotension, and so you don't want to be fighting yourself by causing that and then having to treat it with 2 other drugs, right? Next we have etomidate. This is one that we use very frequently in the case of rapid sequence intubation. We'll talk more about that when we get to the ER section. This one is good for inducing anesthesia in patients who have limited cardiovascular reserve. You'll find that etomidate is very neutral to heart rate and blood pressure, right? So if I give you propofol, blood pressure is going to drop. If I give you barbiturates, blood pressure is probably going to drop. If I give you ketamine, you're probably going to see blood pressure go up. Etomidate is going to be very neutral from that standpoint. This is why it's a very good drug for that, especially if you're having to intubate like a septic patient who's hypotensive. Etomidate's great. Also, it's going to have a pretty minimal respiratory depression. So again, this is going to be, you will still see some for your patients, especially if they're being intubated. You're oftentimes given a paralytic as well, which is affecting that. But the nice thing here is you get a nice induction of anesthesia, but it's very short acting. So it's good for kind of one-time doses where you need to knock them out, and then you can kind of sedate them other things if you need to. And you can notice their initial recovery, less than 10 minutes. And so we'll talk more about this when we get to the RSI section, but just be aware that, look at the durations of action of your drugs and be aware when you might need to redose them, right? So if you're trying to intubate a patient and they're starting to wake up on you, you failed, say 2 or 3 attempts and they're starting to move, like you need to redose with some of these drugs. So they are short acting. That's by design. You want short acting drugs, but you just may need to give them more. Okay. This one is metabolized hepatically, so you may run into some issues that if they have hepatic dysfunction, you may see longer durations of action. Other big adverse effects to note with this one that's kind of unique is the fact that it causes some myoclonic activity. So what you end up seeing is sometimes, especially if you're worried about intubating a patient, you see trismus develop, so they can actually kind of, their jaw kind of lock up a little bit, which may make it difficult to actually get the endoscope in. Or get your laryngoscope to do that. So that can be one thing that you can worry about sometimes. Again, that can be overcome by giving a paralytic, which you're usually giving anyway. You do see some post-op nausea, vomiting, and then you can see this adrenocortical suppression. So basically, the thing we run into very frequently with like our septic patients is that they come in, they're hypotensive, we intubate them with etomidate and say like rocuronium or something. They go up to the ICU and they're having problems maintaining their blood pressure. Some of it may be related to the actual disease process, the actual sepsis they're developing or have. Some of it could be related to other drugs they're on, but in a lot of cases it could be related to this adrenocortical suppression. Basically, they don't have enough mineralocorticoid effects, and so we can combat this by giving doses like stress dose hydrocortisone. It helps to kind of draw more water into the blood vessels and help to regulate their pressure a little bit better. So just be aware that can happen even with a single dose of etomidate. And then one of my personal favorites, we have ketamine. So this is going to be working completely different than what you see with a lot of the other sedative agents. This one is going to be a glutamate blocker by blocking the NMDA receptors. Okay, this is chemically related to PCP. Do you guys know what that is? I mean, old school angel dust, phencyclidine, very old school kind of. And so if you think about angel dust, like what would you think about a patient? How would you envision that patient who's on angel dust? Crazy, wild, strong, very big stimulant effect, right? So they're going to be going crazy. They're going to be ripping people limb from limb, tearing down gurneys, and yeah. So So you're going to see some mild effects, very similar to that. But think about the thing that this is going to have some stimulant effects, right? As opposed to just knocking the patient out, this is going to be look totally different than a lot of those other drugs. Basically what happens, by blocking those glutamate receptors, you cause this dissociative anesthetic state, right? Basically, I kind of describe it as kind of a mind out of body type of experience where the patient is still experiencing pain, they can still experience effects, and they can still have reflexes to that, but their brain's not there. There's no communication happening, and so they're off in Disney World or wherever they happen to be while you're still doing your procedure, okay? So it's very nice because the patient's not going to remember anything what's going on. They even though they may do things like they may moan or they may make noises, they're not there, right? So this is why we always like to warn the parents when patients are getting this drug is that, hey, their eyes may be open, they may be moving around. That's totally okay because the patient's not really aware of anything that's going on, right? They're off somewhere else. So you're going to see good analgesia with this. So this is why we like ketamine, because it provides good analgesia, good amnesia, and basically if you give bigger doses, you can see loss of consciousness, but for the most part, patients are still, they're breathing, their eyes are open in some cases, so they're still somewhat conscious. So this is that conscious sedation we're really talking about from that standpoint. So ketamine itself, it is going to be causing release of catecholamines like epinephrine and norepinephrine, so it definitely has some stimulant properties, which is good. So if you had a patient with low blood pressure, this can help to perk them up, right? So you're definitely going to see increases in blood pressure, heart rate when you give ketamine. It's also going to have some bronchial smooth muscle relaxation effects, so this is good for patients with status asthmaticus. You can actually give this drug, so if you had to intubate a patient with status asthmaticus, you can actually give them ketamine as their induction agent, and that will help to increase some of that smooth muscle relaxation, right? It's going to work in conjunction with their albuterol and whatnot. So very, very good drug. May have some negative effects on ICP, so if they had issues with cerebral edema or something, you probably don't want to give this drug necessarily, so be aware of that. But the big problem you run into with ketamine, does anyone know what it is? This is post-operative dysphoric phenomenon they have basically that occurs. So basically someone's coming out of the ketamine, they're coming out of the K-hole, so to speak, and basically they get very agitated. They can become very kind of combative in some cases. They may be, obviously, the nice thing is when they're coming out, they're just kind of babbling, or they're just, it's kind of like truth serum in some cases. All parents will videotape them like, do you have any girlfriends? And you're going to find that especially adult patients, especially those with underlying psychiatric conditions and things like that, they have a very bad time coming out of ketamine. They're very dysphoric, and it's oftentimes you have to give them benzos just to calm them down, right, to prevent them from being a danger to anyone. You see this less frequently with children, which is why we like to use ketamine for kids, because very frequently you can tell them hey, have a really good dream. What's your favorite thing to do? And they're like, I like to play soccer. Like, all right, just dream about playing soccer. Put them out, and they go have a good soccer game. They come back and they're fine, right? Some adult patients who have they've seen some stuff, they go to weird places on ketamine, and they come back in a weird place. So typically avoid ketamine for the adult patients. That's why you use propofol, right? It's a better just sedative instead of causing kind of these stimulant effects. So again, post-op nausea, vomiting is a big one with this one as well. So you do want to pre-treat with some Zofran. Probably about half the cases you end up seeing some vomiting there. Yep. So again, ketamine, very good drug, but again, know your patients who's going to be better to receive it than others. Even some adolescent patients, teenagers, older teenagers. I sometimes don't even like using this drug in just because you worry about the dysphoric reaction. So it can be pretty bad. Okay, so here, just a quick comparison of the different drugs. You guys can just use that for your review, but I think it's a pretty good comparison here to kind of look at their onset, look at some of their side effects you can see with them, and again, be able to look at the patient. If a test question came up and say, hey, your patient is needing to be intubated. They are coming with severe asthma attack. They're on continuous albuterol and magnesium drips. What would be the best agent to intubate them with? You say, okay, ketamine is probably going to be the best one. Or if you have a patient who's say they're septic and they're hypotensive, maybe Etamidate's a good one to give, versus something like propofol, right? One other thing to note with propofol is because it's in that lipid emulsion, it's actually made out of soy and egg lecithin, so you have those proteins there, so you want to be careful and watch out for things like egg allergies or soy allergies. They may have a reaction to propofol. Okay, so just be aware of that one. Okay, so any questions on the actual drugs themselves? All right, so just going back to the term conscious sedation. So again, this is this drug-induced alleviation of anxiety and pain. And again, it's really combining with this kind of altered state of consciousness that they're developing. And by using kind of adjunctive medications together, you can lower doses of what you need to achieve just the right amount of sedation that you need in order to get the procedure done. Usually the patient, when they're in a state of conscious sedation, they're maintaining a patent airway, so you're not having to intubate them to protect their airway. They may be or may not be responsive to verbal commands. And this is where you're going to see a lot of propofol, ketamine, benzodiazepines are really responsible for a lot of the conscious sedation that you see in outpatient procedures or in the ER. But the benefits of using benzos and opioids is they're reversible. If I give too much ketamine, I can't do anything about that. Just have to give them time. If I give too much propofol, just got to give it time, which is why it's nice that those are short-acting drugs, but you can't really do anything about them to reverse their effects. Okay. Looking at conscious sedation in the ICU, sometimes you need to do this for patients that require other procedures, so if they need to undergo like bronchoscopy, or if they have to have an LP done, or whatever it happens to be, you may require this in the ICU setting. And so again, these patients are usually under a lot of physiologic stress to begin with, and so you need to consider, are they already on mechanical ventilation? Are they already being sedated with something else? And kind of look at your patient conditions to see what drug might be most appropriate for them. But very commonly, you're going to find combinations of both sedatives and hypnotics. Sometimes you may see low doses of IV anesthetics being used. Not super common there, but things like propofol can sometimes be used for maintenance of sedation. And then also you may see neuromuscular blocking drugs, or NMBs. And so these are going to be drugs that are paralytics that will help to allow for better cooperation with the patient, especially if they're trying to buck the vent or something like that. We'll talk more about those when we get to the intubation section in the ER lectures coming up. And then also one other drug is going to be one called dexmedetomidine, or otherwise known as Precedex. So Precedex is a drug you're going to see probably more frequently in the ICU, sometimes in the surgical setting. I've seen a few docs try to use this in the post-op setting, but basically it's an alpha-2 agonist. Do you guys remember any other drugs that do this? Yeah, clonidine is going to be the big one. So this is a very potent version of clonidine, essentially, and so it is working to block those agonize those alpha-2 receptors. It's going to cause decreased catecholamine release, so it's that sympatholytic type of effect, and so it's going to cause sedation. It's going to cause mild decreases in blood pressure and heart rate, and so it's very good for light sedation, right? If I have a patient who's, undergoing general surgery, this is another drug for them, right? This is like if your grandma's getting a little wily, you need to put her, just let her sleep. This is a good drug for that, right? So very, very light sedation, but it also lacks a lot of the side effects like we used to, like benzos and opioids and things like that. Also very short acting. So again, if they get overly sedate, you can just turn it off and they come right out of it. But again, be watchful of the hypotension bradycardia you can see with the higher doses you administer there. It's a very expensive drug because it's relatively new, so it's going to be something you see probably more commonly in ICU settings, probably there primarily, but as a drug whenever it comes off patent, you'll probably see a lot more use of it go up. Okay, and then going from conscious sedation down to like the deep sedation, obviously just it's all on the spectrum, but this is more depressed consciousness. Again, here the patient's usually not easily aroused, and may be accompanied by either the inability for them to maintain their airway or lack of verbal responsiveness to stimuli. And again, in some cases, may be indistinguishable from IV anesthesia, right, or from general anesthesia. Again, all going to be a spectrum, and sometimes you may have patients where you're giving them, you're trying to get them ready for a procedure, and they go from conscious sedation down to deep sedation, right? And now all of a sudden your monitoring becomes very, very different. This is why you always want to have good monitoring teams around. So every time we sedate a patient in the ER, they have an RT at the head of the bed. They have a nurse who's doing the documentation. They have a paramedic who's there to assist, the proceduralist, and then the ER doc who's the actual sedationist, right? I don't know if sedationist is a word. That's the sedation provider. So it's a big team just to sedate these patients, because if they go down the wrong pathway, they get overly sedate. You may need to intubate. You may need to do other kind of rescue maneuvers to protect that patient. So again, just keep in mind it's all a spectrum. Some patients respond differently than others. But this is where you're going to see more, usually combinations of drugs. This is where you see bigger doses of ketamine, opioids, propofol. Again, the airway is going to be the biggest thing you want to be monitoring for to make sure that's being maintained. Okay. So again, choice of anesthetics is going to be dependent on the type of surgery you're doing, so either location or the type of anesthesia you need to achieve, and also the anticipated length of the procedure, right? So if you need, if it's a very quick, reduction of a dislocated joint, or if it's something where you're having to put a very elaborate kind of cast on or something like that, like you may require, the time frame is going to change very, very drastically. Look at the patient's condition. Look at comorbid conditions, age, and then also very important to ask is their previous experience in anesthesia. Have you had family members who've had bad experiences? Have you yourself had a bad experience with, say, ketamine you got before and you had a really bad dysphoric reaction? So those are all good things to ask and make sure you don't give them something they should not receive. Make sure you have good, the right available equipment, meaning you're ready to intubate, you can treat anaphylactic reactions, you got all this stuff. And then also the choice of drug is going to be dependent on the anesthesiologist and the patient themselves. So again, usually you'll find your providers are very comfortable with one type of drug, and that's just what they're going to use forever. So it'll depend on them as well. Okay, so some other adjunct agents you may see being used in conjunction with some of these other sedative agents. Obviously, benzos are very good for controlling anxiety and also facilitate the amnesia. So as I mentioned, you'll see them a lot in the pre-op setting. They'll get a dose, usually oral, Versed or something like that, just to kind of take the edge off before they get the more kind of intensive drugs. Barbiturates sometimes for sedation. The antihistamines can be utilized occasionally. Diphenhydramine and other H1 blockers can be used to help treat allergic reactions if anything happens, or they get like some pruritus or some rash or something like that. Also, diphenhydramine, what's a common side effect with that drug? Get drowsiness, right? So it can also help with the sedation there. Also nice, it has some anticholinergic effects. So we mentioned, secretions can be a problem in the airway, especially if you kind of have that decreased mucociliary clearance. So either suctioning is important or using anticholinergics to help will dry them out, right? So that's where things like diphenhydramine can be big. Glycopyrrolate or Robenol can be utilized as well. So different things to get the same job done. Ranitidine can be useful for decreasing things like the gastric acidity, so that way you're not worried about aspiration of gastric contents. And then obviously ondansetron and other antiemetics are going to be very important. Usually ondansetron is enough for most patients, but you may see very severe post-op nausea, vomiting, where you need to use kind of more bigger guns. But most of the time, Zofrane's going to be good for most patients. Opioids are also going to be important for post-op analgesia. We like to limit those doses as much as possible, so make sure they're using adjuvants like acetaminophen if it's appropriate, or NSAIDs if they're appropriate, because less opioids, the better off they're going to be. Some of our patients, especially that have a very painful procedure done, they'll be put on something like a PCA afterwards. You guys remember what PCA means?
Patient-controlled anesthesia.
Yeah, patient-controlled analgesia. So basically they'll have hydromorphone or fentanyl or morphine or something like that in a continuous infusion device where they can give themselves boluses as they need. That's also been found to decrease total doses of opioids patients receive, and that can also hasten the recovery as well. So that may be something you see for some of the more painful things, big orthopedic procedures and whatnot. It's very common to see PCAs used for those patients. Okay, so any questions on those drugs? Okay, I think I'll be nice and go and cut it here, and then we'll continue on, finish this up, and then move on to the ER stuff for next time. Because if any other thoughts, questions, queries, this will not be on the test for Monday, right? So you guys know where the material ends. Otherwise, I will see you then. Thank you.